Welcome to Spine Conference. Today's discussion will be on pedicle subtraction osteotomies. Unfortunately, this spine conference was not recorded. Earlier today, we had the conference with 5 spine surgeons, our fellow, maybe 5 to 10 residents and students, etc. And unfortunately, due to a technical glitch, I did not record it. So I'm recording it later this evening. I remember most of what was said, and I apologize for this. Happy New Year. So this is case-based learning. We're going to start with this patient 6 years ago. I dug up an x-ray from 2012. She's a 65-year-old woman who presented with low back pain. She has had previous L4-S1 posterior non-instrumented fusion 1985, so 27 years ago. She had very good results, and you can see here AP lateral views. There's a very nice, robust posterior lateral fusion mass, which is very mature. She has L405 decreased disc height, probably had degenerative disc disease. And you can see above at L304, she has developed some spondylolisthesis. On the AP view, you can see very clearly posterior laterally at the level of the facets, there's a nice solid fusion. She did not have surgery at this point. Now fast forward 2 more years to 2014, where she's 67 and she had low back pain and sciatica. You can see here an MRI scan that I found. L304, she's reduced now. So there's a dynamic element to this spondylolisthesis. At L304, on the axial cuts, top right, you can see fluid within the facets. We used to call this gapped facet sign, GAPVD, or you can call it fluid within the facets. Basically, it denotes dynamic spondylolisthesis, and she has a right-sided L304 disc herniation. Interestingly, look at L203, sagittal cuts. Looks totally normal. Axial cuts looks pretty normal. Some mild hypertrophy ligament of flavum, maybe some mild enlargement of the facets, not much though. It looks pretty normal. So patient, I'm very sorry about this, but the patient had an in situ L304 fusion, in situ in the sense that she had spondylolisthesis, which was not reduced. There's a laminectomy and fusion. It's a very bad x-ray, I apologize. So now fast forward to the current day, November 2018, where the patient's 71 years old, and she presented with bilateral lower extremity weakness and progressive debilitation over the last 3 years. She has diffuse bilateral lower extremity numbness, and she cannot walk, and she says her legs do not follow her commands. Again, the past medical history we discussed. Past medical history is significant for anemia, hypertension, psoriasis, chronic renal insufficiency, rheumatoid arthritis. She's had a transvaginal hysterectomy. She presented to the office November 2018. So you can see on the AP view, spine is pretty straight on the AP view. The right L304 screws look good. The left one's a little bit suspect, maybe lateral. On the lateral view of the entire spine, she has a pretty significant thoracic kyphosis, more than usual. A plumb line, which is dropped from C2, is way anterior to the sacrum. A plumb line from C7 looks like 3 to 4 centimeters anterior to the sacrum. And a plumb line from the middle of T12 is the very anterior portion of the sacrum. So her body, her torso, is definitely pitched forward. You can see here at the level above her fusion, L203, which again was normal. If you go back 4 years, it was totally normal. L203 is normal. Now has severe sclerosis of the end plates, 2-level spondylolisthesis. The L3 vertebral body is not horizontal. It should be straight across, so she's pointing downwards. Again, the AP view looks like the left side screws and maybe lateral to optimal. So just in general, thoracic kyphosis ranges around 10 to 40, should be 35 degrees. Lumbar lordosis, again, there's a range, 40 to 60, should be around 55. The C7 plumb line, sagittal vertical axis, should strike the posterior superior corner of S1. So here in this patient, C7 is way anterior to the sacrum. And I think this pitched forward or flat back deformity, anterior displaced sagittal vertical axis is the cause of this spondylolisthesis. You can see here on the CAT scan, L203 has a grade 1 spondylolisthesis, almost grade 2. The disc is gone, and it's very sclerotic, and she has really deteriorated very quickly over just 4 years. And I think it's because of her deformity. Basically her torso is anterior displaced, and this is causing stress at the first mobile segment. At L304, I think she also has a non-union. You can see there's a black line across where there should be a fusion mass. So that just adds to the problems. If you look at the axial cuts at the level of L4, there's a halo loosening sign around the right L4 screw, suggestive of non-union. So this is the old school way to take bone graft. You notch the lateral portion of the ilium, then halfway through the ilium you remove corticocancellous strips, and then the middle part you take the bone graft and you use the strips. And this patient had this type of bone graft harvest. You can see on the right the deformity, and it's mostly healed, interestingly, but it's a bit deformed. So the reason why I bring this up is I'm going to use the ilium for fixation. It's something that you have to keep an eye on. This is the level of the spinal canal at L2, L3. These are the L3 pedicle screws, and you can see here the facet is encroaching in the spinal canal. It's about over halfway into the spinal canal. So the spine is sliding forwards. The L2 vertebral body is going forwards on L3. She has anterior listhesis, and the facets are going forwards into the spinal canal, causing severe stenosis at L2, L3. Axial cuts through the L2 vertebral body show she has very small pedicles. On the right, 3.5 millimeters, on the left, 4.8 millimeters. So I don't think I can put a screw here on the right without encroaching the cortical wall of the pedicle. Same thing as L1. On the left, 4.6 millimeters. On the right, 3 millimeters. There's no screw. That's that shape. So why not do the in-out-in technique? So in the thoracic spine, you can do this because the thoracic nerve roots do not cause symptoms if you compress them. So basically, in-out-in is you're in initially, but then out lateral of the pedicle and then into the vertebral body. This is good for thoracic screws, but for lumbar screws, excuse me, it doesn't work so well. And the reason is, here's a coronal section of anatomy. In the middle is the spinal canal. This is the L3 pedicle. This is the L3 nerve root. The L2 nerve root from above sometimes hugs the lateral portion of the pedicle. So if your screw is lateral, and especially in the lumbar spine, you very frequently get compress this nerve root with the screw if you're lateral, and it causes symptoms. So I don't think you can do this in the lumbar spine. T12, as most people with some experience in these matters, she has very large pedicles, so T11 was good, T10 was good. So basically she has 2 levels of spondylolisthesis, L2, L3, and L3, L4, staircase step deformity. This is her CT, and this is the normal CT on the right. And you can see she has 40 degrees of lumbar lordosis, L1 to S1, which is not too bad. The MRI scan shows stenosis at L2, L3. Here's an axial cut. You can see that due to the spondylolisthesis, the facets are anterior into the spinal canal. So in these cases that I think have many things going on, I like to make a problem list to basically to organize my thoughts and understand what are the problems. So first is chief complaint. You always have to fix the patient's chief complaint, because if you don't, they'll keep complaining and it'll be a problem. So the chief complaint is lower extremity weakness, unable to walk. And this is mostly due to the L2, L3 stenosis, compression over nerve roots that go to the lower extremities. And it's been rapidly deteriorating over the last 4 years. Why? I think because of the flat back deformity and the fact that her torso is anteriorly displaced over her pelvis. She also has an L3 non-union, L3, L4 non-union, most likely from the previous surgery. 2 levels of spondylolisthesis. Again, like we said, the gravity line is anteriorly displaced. There's a solid fusion from L4 to S1, something to keep in the back of your mind. Very small pedicles on the right at L1, L2. And very small pedicles on the left, really, and osteoporosis. So this is just a slide of Union Memorial Hospital in the 1950s. So flat back deformity started with Paul Harrington. He was a national javelin champion, I think, in college. He's from Kansas, and in World War II, he served our country, the United States, as a surgeon, and was a chief of a hospital. He created a rod to treat scoliosis. And in Baylor, he's from Baylor, Texas. Between 1960 and 1990, there were 1 million cases of scoliosis. And you can see basically the Hairton rod was a distraction device, and it distracted in one plane, but on the lateral view, it created a flat back deformity. So basically, you lose your lordosis when you distract, and the lumbar spine would become flat. And then above it, you would sometimes get a flat back deformity. On the right, you can see here, these are the implants themselves. And this is the leaning tower pizza. If you have an unbalanced structure, it causes a lot of stress. So I like to think of military posture as the best ergonomic posture you can do. These soldiers can stand at attention for 12 hours without getting tired, and the reason is because they're very balanced and their head is over their torso. And you can just see this picture of this young woman that she's not balanced, and you can just get an idea that this is sort of an exhausting posture. People have to live like this with the flat back deformities. This is a young man who is adjusting his spine, tilting his pelvis, flexing his hips, flexing his knees, and you can see that you can adjust your body to maintain a horizontal gaze, but it can cause deformities of the rest of your body. And this is just some generalized markings, the way to measure it. Now, the shape of your pelvis can affect the rest of your spine in the sense of pelvic incidence. So if your pelvis is shaped in certain manners, it asks a lot from your spine. For example, if you have a high pelvic incidence, which is here on the right, this is basically the shape of your pelvis, sacrum, and the hips. It asks a lot of your spine to be straight. So if you have a high pelvic incidence, you need a lot of lumbar lordosis to look straight. So it kind of changes what you need. And low pelvic incidence is the opposite. I usually use the sacral horizontal angle as a ballpark measure of what the sacrum looks like when I measure these things. So how do you reduce this deformity or fix it surgically? Basically, the only thing that you can do is a 3-column pedicle subtraction osteotomy, and it gives you 30 to 40 degrees of extension of the spine. Basically, you remove the pedicle and the vertebral body anteriorly, and you close it down, and you reduce the deformity. This is obviously, an osteotomy is a serious operation, even if it's the tibia or the radius. But in the spine, it's even worse because basically the osteotomy is through the spinal canal where there are nerve roots. So remove the posterior elements, remove the pedicle. This is a study from Neurosurgical Focus from 2014, which I thought was the best study going over complications. 423 patients, so it's a lot of pedicle subtraction osteotomies. And if you look at the names of these surgeons, they're the best surgeons in the country. So they're very experienced. And they had a very high complication rate. Intraoperative complications, 7%. Postoperative complications, 39%. Overall, 42% complications. Almost half of all patients had a complication. Spinal cord deficit, 2.6%. Major blood loss, over 4 liters. Remember, the human body only has 5.6 liters. Is 24%. So a quarter of these patients lost over half of their blood volume. And the average blood loss was 3 liters. So I put this slide up just to remind people that when I do a pedicle subtraction osteotomy, I give it the same seriousness and care of thought that I used to do when I used to do a below-knee amputation. It's a very serious thing for the patient, and you have to be, I think you have to be really very sure that this is the only operation that will work because the complication rate is so high. So I give it the same seriousness as I used to do with a below-knee amputation. There are different types of osteotomies. Smith-Peterson is 1 and 2. 3 is, this is a Schwab classification, is through the pedicle and middle of the vertebral body. And 4 includes the disc. 5 and 6 are removing the whole vertebral body. During the operation, to protect the soft tissues in the abdomen, you have to put a 4x4 anteriorly, and the other thing you have to remember is there's a segmental vessel here that could bleed a lot. It's in the middle of the vertebral body, And it's very rare to catch it with pedicle subtraction osteotomies, but it's possible. So what I do is, for these procedures, I call the vascular surgeon in the hospital and I have him on standby. I give him a percentage of 1 in 50, a 2% chance I'm going to call him for a serious problem. I've never had to do that. This just shows you the Smith-Peterson osteotomy, which relies on basically distraction of the very anterior portion of the column of the spine. Now, I have some experience with these matters, and I prefer to go through the disc space because I think you get more correction going through the disc space. The other and very important issue with these pedicle subtraction osteotomies is you have to be 100% sure that you have basically a double frame and you have 2 nerve roots in this very large frame that you have created, and you have to be sure that those nerve roots are open and you have to explore them. Now, when you put the patient in the prone position, they're usually somewhat kyphotic, and the OSI Jackson table is very good for that. And then after the osteotomy is completely done, you reduce the deformity with the table by just, you can see there's an elbow right there at the level of spine. You just ask the anesthesiologist to hit the button that makes it straight, and you have to show the anesthesiologist because during the procedure you're tired and the anesthesiologist is going to forget. These are Lamb-Bott osteotomes. That's what I prefer to use the cup, but there's many different types of osteotomes that you can use. This is an excellent open access study that I found in 2011, very interesting, of how the body adapts to spinal deformities to make sure the patient looks straight. So basically the patient's spine either becomes hyperlordotic or kyphotic, or the hips flex or the knees flex to maintain an upright posture. And it's important to understand how the patient is compensating and what different deformities are in the body. So it's just not the area of what you're looking at as a spine surgeon, usually lumbar, thoracic spine, or cervical. You have to understand the patient may have a flexion contracture of the hips, may have flexion contractures of the knees. They may just be standing flexed and there's no contracture. Also, the pelvis may be rotated. You remember that young man I showed you? People can compensate. And other parts of the spine may be compensating. So this is just a Thomas test, how to evaluate hip extension. I make the patient lay completely flat on the exam table. This is a patient with ankylosing spondylitis who could not put her head backwards. I lay them completely flat just to see what I'm dealing with and see how much extension I could get. If the patient has severe hip flexion contractures, it's something that you have to deal with, either with maybe a total hip arthroplasty preoperatively, or maybe physical therapy, put the patient in a prone position to flex the hip flexors, but it's something that you have to understand preoperatively. I showed this slide just to remind everyone that the superior screws have a tendency to cut out, and fenestrated screws, where you can insert cement through the screws into the vertebral body, gives you added strength, pull-out strength for the screws. And I like to use these DePuy Synthes has screws like this. This is just different ways that you can instrument pedicle subtraction osteotomies. The first one on the left is basically just one rod. So I think of the spine as in 2 blocks, the superior portion, inferior portion, and usually you have 6 points above, 6 points below, and you can just use one rod, very simple to use. You want to make it easy and fast. The satellite rod, I think, is helpful if you have very strong pedicles just above and below the pedicle subtraction osteotomy, and you can close it down with the short rod, and then the 2 satellite rods give you extra strength, and cross-linking them is a good idea. And this is a nice method that Dr. Kabesh has a very nice YouTube video where you put 4 rods in above and below, and then a 5th and 6th rod on either side, and you squeeze down on these rods with the compressors and then cross-link. So this puts even stress on all of the screws, decreases the probability of cutout. This on the left is the case of mine where I use satellite rods. This is like 6 months post-op, and this cap popped off. Patient did very well, though. I found it on the internet. This is a 6-rod technique. So this is back to our case now. For these complex cases and osteotomies, what I like to do is draw a cartoon of exactly the deformity, and then on a piece of paper, print out 5 or 6 of these pieces of paper, and then make different wedges, like different plans and different ways that you can do it. So I in this patient, there was just 2 different options I thought were reasonable, either an L3 pedicle subtraction osteotomy or an L4 pedicle subtraction osteotomy. And I cut them out and I tape them and I look at them and I think about them and I go over the risk benefits of all the different treatment options. In this patient, I felt L3 was the best place to put the pedicle subtraction osteotomy. Reasons are it's at the level of the non-union. I already had a good L4 pedicle screw. I mean, I did remove it and place a new one in and redirected it on the left, so it's a better screw, but it was pretty easy to do that. I wanted to decrease the time. And this is my preoperative plan. So basically, before every operation, I have exactly every single step that I have to do for the whole surgery. And the reason is, just when you do these cases, you get tired and you don't want to miss a step. So if it's written down and it's printed and in the operating room, it's just very easy. You go up to it and look at it if you get tired or if you forget, just to confirm you did everything right. So here's the post-op of this case. The case went, I believe, extremely well. It took a long time, though, 7.5 hours. I added another 30, 45 minutes because I wanted pedicle screw fixation both above and below the pedicle subtraction osteotomy. And on the left, if you remember, the pedicle is really small. So what I did was laminotomies at both of these levels, and I had a pin field 4 on the medial wall of the pedicle just so I knew exactly where that pedicle is. And then I put the screw in, and I could do it. I think I could not have done this accurately without a laminotomy. And if you miss the pedicle, you only get one shot. If you miss it, that's it. You can't really put a screw in safely. So you can see the most superior portion. I went up to T10 because one of my partners explained to me that T10 is the first full rib that goes all the way anteriorly into your chest, and it ties into the entire rib cage because T11, T12 ribs are free. So it gives you a stronger fixation superiorly. And I put cement about 1.5 cc's in each vertebral body at T10 and T11. I put iliac screws bilaterally. I used the old 4 screw hole, redirected the left one. And you can see here my osteotomy, the L3 pedicle osteotomy, and how much correction I got at L2, L3. The case took 7.5 hours. I lost 1.1 liters, which is a lot of blood. Most of the blood loss was at the time of the osteotomy. The vertebral body bled a lot. 4.5 liters back, 1 unit of packed red blood cells, 1 unit of fresh frozen plasma. The other thing is I have a rule that once I get to 1 liter of blood loss, I tell the anesthesiologist before the case that the anesthesiologist must tell me when I hit 1 liter of blood loss. And the reason is I think at 2 liters, you basically have a very high risk for DIC coagulopathy. And it usually takes 45 minutes to thaw the fresh frozen plasma. You have to call the blood bank, and there's a process involved. And it takes time. So I think that has to start at 1 liter, because by the time you get to 2 liters, it's going to be too late to get your fresh frozen plasma, and the patient can become coagulopathic and basically bleed to death. So I think this process has to be started when you're at 1 liter blood loss. And you can see here the before on the left, the after on the right, how much extension now is at the torso, which I needed for her. These are just the post-operative CAT scan showing the T12 screws and the cement in the vertebral body. The iliac screws, they give you very strong fixation. On the right, there's a deformity, and I had to avoid that deformity. Here's the pedicle screws at L2, and you can see there's no room for error here. It has to be bullseye. So you can see my laminotomy, and I had a penfield 4 here feeling the medial wall of the pedicle while I inserted it to make sure I was perfect. Same thing at L1, laminotomy, to feel the medial wall of the pedicle to get the screw just right. Here's the post-op CAT scan. I always order the CAT scan the night of the surgery because if there's going to be a problem, I want to know it right away. If I have to take the patient back, I'd like to do it the next day just to get it over with. And just the measurement, you can see here the plumb line from T12 goes through the sacrum, which is an excellent correction. You can see here at the level of L203, the pedicle subtraction osteotomy, and how much lordosis we got at that level. Also note the at L203, it's through the disc base, and the posterior cortex of the vertebral bodies are closed down. I mean, in retrospect, I think it would be nice if we could have inserted a cage anteriorly to increase the rate of fusion and also maybe get a little more lordosis, but that would add more time to the case. So it's something to think about, inserting a cage anteriorly at the level of your pedicle subtraction osteotomy to ensure fusion. Again, the iliac screws, and just the before and after, here's the plan that I had on the left and the after CAT scan, just comparing it. I think the spondylolisthesis reduced fairly nicely at the level of pedicle subtraction osteotomy, and there's excellent correction. So that's the case, pedicle subtraction osteotomy. If anybody has any questions or comments, please feel free to put it in the comment section. Thank you, and I'm sorry that I don't have the comments from the other surgeons. See you next month.